And we have the last lecture of this session, and we'll have George Dangas talk now on durable polymer versus bioabsorbed polymer. Some of it were touched by Dr. Greg already. Over to you, Dr. George. Sorry for...
Great. Thank you for inviting me. It's been great to hear and see Greg and Ajay and everyone else. Great. So I get a chance today to talk to you and have a lively discussion, perhaps if there is time left, regarding durable and biodegradable polymer drug-eluting stents, as if we can make some sense out of this. We have too many stents to discuss. These are my related disclosures. I'm going to try to group them in order to go forward. As probably indicated in this conference earlier, we have the aspects of recoil and negative remodeling, as well as the neointimal hyperplasia, and the stents have been very successful in isolating one versus another and make us focus on neointimal hyperplasia as a main mechanism of restenosis after stenting, provided the stent is adequately expanded, as alluded in your other sessions, and ultimately how we can target the neointimal hyperplasia by adding a drug on top of the stent. In order to do that, we have to have some type of a polymer in order to hold and elute the stent over the time. May I say also there are some innovative designs of stents without any polymer. I'm not going to go into that at all today, but they do exist. The current DS technology, and forget about looking at the small font, I just want to show you how different the struts are and how much they differ. So just an aerial view of how big or small some of these struts are, the cross-section of the struts. It gives you an understanding of not all metallic stents, or the metallic part of the stent, are not created equal. And even further, there's some research, basic research, indicating that the thinner of the strut, the lower the degree of injury induced by the metallic stent, and the less chance of uncovered stents and less chance of further problems down the line. So in general, thinner strut are preferable, although one must also caution that this is not extensive clinical data. This is just hints from mechanistic studies. An example of the drug-eluting stent with durable polymer that I'm going to talk quite a bit because it's been used in many trials is the Xience durable polymer that indicates that includes the coating technology with the fluoropolymer, the multi-link design, and the overall IMU stent with an elution principle for specific elution kinetics. Just to again give you an aerial view of how different the stent designs may be among different kinds of stents, you can also see this one here, the peak-to-valley, the peak-to-peak designs of the various stents, and even among the peak-to-peak on the right-hand side, you can see that they vary quite a lot among each other. So adoption to the band, sidebar access may have a lot to do perhaps with CKMB elevations after the procedure or other issues that we may encounter, including deliverability, etc. And obviously, the more deliverable the stent is, the drug-eluting stent is, the less banging or the less injury the stent device itself sustains in the trip throughout the coronary arteries towards a lesion, with less chances of losing parts of the polymer or the drug, and therefore causing some form of geographical miss, some form of non-eluted drug in certain aspects of the vessel wall due to prior injury the stent may have sustained during navigating the proximal vessels. This is a few more details about the fluoropolymer. I think it's very important to understand that this also has been used extensively in the vascular endovascular graft procedure for many years by different manufacturers. It is well, in many ways, it is well, it's very well described and utilized in cardiovascular medicine. I want to stay very shortly to the clinical results of last year with the Xience 28 and 90. This means essentially monotherapy after 28 or 90 days. This is the trial designs with aspirin alone after this type of original dual antiplatelet therapy. And in general, They met their endpoints, which are historical control of the Science v. United States database, highly significant for the Science 80, similarly highly significant for the Science 28. And as far as the combined endpoint, always we're interested in interventional cardiology. Stent thrombosis is very close to our heart. Very, very low stent thrombosis, 0.2%, despite the early interruptions of the various things, and 0.3, the definite. The bleeding, needless to say, with less with aspirin monotherapy versus dual antiplatelet therapy, you have a lot of bleeding savings in both of them between 3 and 12 months and between 1 and 6 months. So you have the bleeding savings and you maintain efficacy, very clear results in this aspect. So let's move on to the no polymer, no roller polymer, and how about the biodegradable polymer technologies may have brought on some kind of a revolution here. If you don't need the polymer long term and you just need it to elute the stent, how about the polymer goes away shortly after it elutes the stent? And why would that be? Because theoretically, particularly with the first generation stents, there were certainly some, not that many, but certainly some hypersensitive reactions and inflammation due to the polymer. Again, what kind of polymer? Maybe they weren't exactly fluoropolymers, and were other polymers, and nonetheless, they were polymer-related hypersensitive reaction. Over here, I want to say also, when you hear biodegradable polymeric stents, one can say that, sure, the strengths and weaknesses allows a prolonged drug release, minimizing risk stenosis with a durable polymer. Ultimately, the polymer itself, for example, the fluoropolymer may have anti-inflammatory and antithrombotic effects, sure, or may improve the stent biocompatibility, certainly, well, but others may not. So you have to be very specific what polymer you're talking about. And the durable polymer come in and say, you know what, well, we're going to all go away. And again, you have to think about it. Some of the biodegradable polymers, they don't go away until a year or so. Is that short enough, for example? If the drug is eluted by a few months, is it short enough that the biodegradable polymer goes away in a year or two? Maybe it's not. So again, you have to be very specific. What is the kinetics of the drug elution and the kinetics of the biopolymer disappearance over the time? So these are some examples of newer generation biodegradable polymer. The top one particularly includes not only the PLLA polymer, but also an ultra thin, super thin metallic stent, 60 microns. And I think that's where also we have to pay attention. Not anything is okay, well, BPDS or DPDS and everything else kind of all the same. Sometimes BPDS may be combined with a super ultra thin stent strut, and that may have certain merits. Let's see how the trial have become. First of all, there's a complex network meta-analysis. I don't need to state the word complex. You can all see on the left-hand side how complex the diagram is of all these comparisons. The cobalt chromium everolimus eluting stent is a common comparator in the middle, and most comparisons have been done with this stent, and you can see on the right side the long-term definite stent thrombosis, not a tremendously lot of difference except for one, the of the stent, the BPB by BS in the one before the last, and the long-term definite or probable stent thrombosis, not a lot of difference between the two, unless the top ones that includes the nearly obsolete bare metal stents, as Dr. Stone alluded right before, as well as a well-known obsolete stent, paclitaxel eluting, that's no longer manufactured or distributed. Talking about some trials with biodegradable stents, you can see that they try to compare with the biodegradable polymer. The results are sure they're on the non-inferior aspect, but the stent thrombosis is just a tad higher with the biodegradable polymer. This particular design that you see here in the Swiss trial. And then we have the idea left main trial. Obviously, when it's a left main, what is it? Is bigger size stents, and in the bigger size stents, one can say that perhaps the non-inferiority worked out much better, and there was not a lot of difference in the two groups when the stents are in the biggest of the sizes. A further trial was presented in just last TCT, a rather complex name coming from South Korea, the host-reduced polytech ACS trial. In ACS patients, you can see the comparator there on the right-hand side. Durable polymer was that biodegradable polymer, DS, and overall, the results were rather similar. There was a penalty towards a higher target lesion revascularization, and the related device-oriented secondary endpoint was slightly higher in the slightly higher in the biodegradable polymer DS, but overall the numbers were rather low, one can say. And this was what underlined this whole situation was that you only had an extraordinarily low 0.1% stent thrombosis with a biodegradable, with a durable polymer, fluoropolymer DS, here extraordinarily low, so that even a great rate of 0.4% came out to be higher than 0.1%. Numerically, not statistically, but again, at the device endpoint, there was other TLRs as well, drove up the endpoint in the over the statistical significance bar for the biodegradable polymer in this very large South Korean study. Talking about Orsiro itself, again, the combination biodegradable with a super thin strut, 60 microns. I'm sorry, I'm missing the micron, is not 60 meters. The thin strut is micrometers. And you can see that the clear result in favor of this type of stent versus the durable fluoropolymer in this one study. The BioFlow trial that you can see here, the 2-year results, the original results rather durable over the time in all aspects of how you compare it. The red is higher than the blue event rates. Talking about in an Indian course, I must also say that the BioMime stent is not available in the United States, however, is again a sirolimus eluting stent with a very thin strut and indicates some good results of non-inferiority regarding the drug-eluting stent, the biodegradable polymer, the durable polymer, fluoropolymer drug-eluting stent. And again, over here, they have again a combination of biodegradable polymer with a 65 micron strut thickness. Again, maybe that's a good combination, ultra-thin plus biopolymer, time will show. So in conclusion, we know that current durable polymer drug-eluting stents have appreciably improved safety and efficacy profile compared to the first generation DS, and this is particularly true with utilization of the fluoropolymer, which has been used widely in endovascular stent graft for many years before from other manufacturers. Biodegradable DS come in offering great advantages over, in general, the durable polymer DS. However, we have to all understand that they're not a homogeneous class of devices. Not all are the same. There are some ultra-thin biodegradable polymer. Maybe this emergence has something more to say. We need to understand that both biodegradable polymer DS and comparable durable polymer are non-homogeneous groups, and individual stent design comparison should be guarded. So in my opinion, the appropriately sized randomized trials are needed to further determine specific stent design, specific stent to stent, because we have 3 parameters: the polymer, the drug elution, and the type and thickness of metallic stent struts. Thank you so much for your attention.
Thank you, Dr. Dangas, for that lecture. Yeah, we have a science platform, which is the leading strength in the country, probably has about 1/4 share in the country. We wanted a talk specifically on that. And we should also thank Abbott Vascular for not only in spending some money for the meetings, but also helping in organization of the meetings. They become part of our organization team. I think Ajay and Greg, all of you know how to organize meetings better. But it's always helpful. Now we also have OCT with them. They have been also helping us in taking this technology to various places. We thank Abbott for making this possible for in our country. And with this, I think live cases are scheduled to are waiting already. We are slightly delayed. Any final words before closure, sir? We have to leave. You said, Dr. Greg.
Not for me. I'd like to thank you for the invitation. I don't know if any of the faculty of the moderators or the panelists would like any comment regarding, but I think it was a very inspiring talk by Dr. Stone before, and I'm glad I got a chance to also fit in and chip in before your live case program.
Thank you, Dr. Stone. You would like to say anything because you have to leave, you said?
Thank you. No, this was a terrific session. And, you know, again, I really want to emphasize that the growth in interventional cardiology has really been driven by the advances in technology, our drugs, the techniques that we apply. Of course, you can't test every single one of those in a randomized trial, but they've made a huge difference, and driven, though, all by the science and the careful collection of data and transparent reporting. And I think in that regard, our subspecialty has really served as a shining example for all of medicine. And this has been a great session because I think you've had, you know, as faculty, some of the key people that have contributed a lot of the data and a lot of the evolution in our thought processes that have happened both from India and the United States over the last 3 to 4 decades. So thank you again for giving me the privilege to be part of this session.
Thank you, sir. I think